contrast to adults, children B have proportionately larger hands. 2. Compared to adults, the smaller diameter of a child's airway makes it more vulnerable to a laryngospasm, B inhalation injury, C oropharyngeal secretions, D obstruction by the tongue. D obstruction by the tongue. 3. A child's vocal cords can be difficult to visualize during intubation because the epiglottis is floppy and U-shaped. B. The cords themselves are more posterior. C. A sniffing position is difficult to achieve. D. The area of the cricoid cartilage is narrow. The epiglottis is floppy and U-shaped. B. Children are belly breathers because they rely heavily on their diaphragms. 5. When a child experiences a low cardiac output state, he or she relies most on A. Increased tidal volume, B. Central vasoconstriction, C. An increase in heart rate, D. Increased stroke volume. C. An increase in heart rate. 6. Most children begin to develop stranger anxiety between blank and blank months of age. A 3, 6 by 6, 12 C 12, 18 D 18, 24. B 6, 12. 7. Children between 1 and 3 years of age, A. are capable of basic reasoning. B. have a well-developed sense of cause and effect. C. generally explore the world exclusively by crawling. D. may have negative associations with healthcare providers. D. may have negative associations with healthcare providers. 8. The first step in examining a toddler in stable condition is to A. let the child sit on a parent's lap. B. place yourself at the child's level. C. quickly examine any painful areas. D. allow the child to hold a favorite toy. A. let the child sit on a parent's lap. 9. When assessing a 5-year-old child, you should A. be able to conduct a head-to-toe exam. B. ask simple yes or no questions if possible. C. generally use a toe-to-head exam approach. D. first ask a parent where the child is hurting. A. be able to conduct a head-to-toe exam. 10. An 8-year-old child, A. is analytic but is not capable of abstract thought. B. should not be the initial historian regarding an illness. C. is anatomically and physiologically similar to an adult. D. generally requires little reassurance and encouragement. C. is anatomically and physiologically similar to an adult. D. secondary sexual characteristics have developed. 12. A 15-year-old child can be difficult to treat for all of the following reasons: EXCEPT, A. peer pressure, B. stranger anxiety, C. independence issues, D. cognizance of body image. B. stranger anxiety. D. may have a weapon and a reputation to earn. B. he or she will be a source of important information and assistance. A. provide support, but remember that your first priority is the child. C. help EMS providers form a hands-off general impression of an ill child. 17. The pediatric assessment triangle will help answer all of the following questions: EXCEPT, A. Is the child sick or not sick? B. Will the child cooperate during my exam? C. Does the child require emergency treatment? D. What is the most likely physiologic abnormality? B. Will the child cooperate during my exam? 18. A sick or injured child's general appearance is most reflective of the etiology of the problem. B. His or her cardiovascular status. C. His or her central nervous system function. D. His or her ability to be consoled. C. His or her central nervous system function. 19. A child who is disinterested in your presence and has a blank stare and poor muscle tone, A. is likely hypoglycemic or in septic shock. B. should be ventilated with a bag mask device. C. will most likely require pharmacologic support. D. requires immediate intervention and transport. D. requires immediate intervention and transport. C. Auscultating the lungs for adventitious sounds. A. is trying to align the axes of the airway to improve ventilation. 22. In contrast to adults, retractions in children are more evident in the intercostal area. B. less commonly seen below the sternum. C. usually less prominent above the clavicles. D. evident in the sternocleidomastoid muscles. More evident in the intercostal area. B. peripheral vasoconstriction and compensated shock. D. acrocyanosis is cyanosis of the hands and feet, and is a normal finding in infants younger than 2 months of age who are cold. C. is used to estimate a child's weight based on his or her height. B. may yield a falsely low respiratory rate because infants may have periodic breathing or variable respiratory rates with short periods of apnea. A. may be observed if the child has been breathing rapidly with increased work of breathing and is becoming fatigued. B. it should be evaluated in the context of the pediatric assessment triangle and remainder of the primary assessment. 29. Early hypoxia in a child would most likely present with a tachycardia. B. bradypnea. C. mottled skin. D. bradycardia. A tachycardia. 30. If you cannot palpate the femoral pulse in an unresponsive infant, you should A. apply an AED at once. B. palpate the brachial pulse. C. initiate CPR immediately. D. assess for adequate breathing. C. initiate CPR immediately. 31. Assessment of a child in a cold environment with most likely yield a rapid, weak pulse. B. flushing of the skin. C. delayed capillary refill. D. a slow, irregular pulse. C. delayed capillary refill. C. blood pressure may remain adequate in compensated shock. 33. To evaluate function of an infant's or child's cerebral cortex, you should A. assess pupil reaction. B. use the AFPA scale. C. assess for posturing. D. evaluate motor activity. B. use the AFPA scale. Your ability to assess accurately for physiologic abnormalities is impaired. 35. The decision to transport an acutely ill child immediately or remain at the scene to perform additional interventions is least dependent on A. The child's age and fear level. B. Transport time to the hospital. C. Expected benefits of treatment. D. Your EMS system's regulations. A. The child's age and fear level. 36. Which of the following is often not acquired during the sample history of an adult, but should be routinely acquired in an infant or child? A. Prescribed medications. B. Nature of symptoms. C. Preceding events. D. Immunizations. D. Immunizations. 37. In contrast to adults, cardiac arrest in children is usually caused by A. Dysrhythmia. B. A toxic ingestion. C. Respiratory failure. D. Congenital anomalies. C. Respiratory failure. B is a compensated state in which increased work of breathing results in adequate pulmonary gas exchange. C. He or she can no longer compensate, which causes hypoxia and hypercarbia. A. Falling oxygen saturation despite high-flow oxygen administration. 41. Diffuse rales, raunchy, and wheezing in an infant. A can usually be heard without a stethoscope. B are typical signs of lower airway inflammation. C suggests swelling of the supraglottic structures. D are signs of acute asthma until proven otherwise. B are typical signs of lower airway inflammation. D. A method that minimizes metabolic demand and oxygen consumption. D. The esophageal foreign body can compress the relatively pliable trachea. C. An afebrile child with a sudden onset of coughing or gagging while playing. B. Perform 30 chest compressions, and then look in the mouth. 46. If a 2-year-old child with a foreign body airway obstruction becomes unresponsive, you should position him or her supine and then A. Visualize the upper airway. B. Perform chest compressions. C. Assess for a carotid pulse. D. Perform abdominal thrusts. B. Perform chest compressions. 47. Appropriate treatment for a conscious child with anaphylaxis includes a 0.5 mg per kilogram of diphenhydramine IV. B. 0.01 mg per kilogram epinephrine 1000 IM. C. Pharmacologically assisted intubation. D. A dopamine infusion to increase the blood pressure. B. 0.01 mg per kilogram epinephrine 1000 IM. D. Croup is a viral upper airway infection that may cause stridor. 49. The most important initial treatment for a child in respiratory failure due to suspected croup is a prompt intubation before the airway closes. B. A 2.25% concentration of racemic epinephrine. C. Ventilatory assistance with a bag mask device. D. Continuous administration of a beta-2 agonist. C. Ventilatory assistance with a bag mask device. C is rare now that children are vaccinated against Haemophilus influenza type B. A. Transport him or her to the hospital with a maintainable airway. 52. In contrast to upper airway emergencies, lower airway emergencies often present with more prominent retractions. B are generally associated with high-grade fever. C include laryngotracheal bronchitis and diphtheria. D involve restriction of airflow during exhalation. D involve restriction of airflow during exhalation. 53. A child who is experiencing a moderate asthma attack would most likely present with a markedly prolonged expiratory phase. B. Wheezing during inspiration and expiration. C. An inability to speak in complete sentences. D. An oxygen saturation between 80% and 90%. B. Wheezing during inspiration and expiration. 54. Medications used to prevent an asthma attack include A. Inhaled steroids. B. Beta-2 agonists. C. Inhaled albuterol. D. Oral ibuprofen. A. Inhaled steroids. 55. Which of the following represents the correct drug, dose, and delivery route for an 18 kg child experiencing severe respiratory distress due to bronchospasm? A. Albuterol, 1 mg nebulized. B. Pratropium, 0.5 mg nebulized. C. Albuterol, 0.25 mg nebulized. D. Epinephrine, 0.1 mg per kilogram IM. B. Pratropium, 0.5 mg nebulized. D. Bronchiolitis is a viral infection of the lower airway that commonly affects infants and children younger than 2 years of age. 57. To maintain a neutral airway position in an unresponsive infant, you should A. Slightly extend the infant's head. B. Pat underneath the infant's occiput. C. Place a towel roll under the shoulders. D. Insert an appropriate-sized oral airway. C. Place a towel roll under the shoulders. 58. An oral or nasal airway in an unresponsive infant or child may serve all of the following purposes, except A. Facilitating oral suctioning. B. Averting the need for intubation. C. Replacing manual head positioning. D. Helping to maintain an open airway. C. Replacing manual head positioning. 59. When inserting an oropharyngeal airway in a child, you should A. Use a tongue blade to depress the tongue. B. Open the mouth with the tongue jaw lift. C. Hyperextend the head to facilitate insertion. D. Suction the oropharynx for 15 seconds first. A. Use a tongue blade to depress the tongue. A. The diameter of their nose is small and easily obstructed by secretions. 61. Proficiency in ventilating apneic infants or children with a bag mask device, A. Cannot be achieved by practicing on a mannequin. B. May avert the need for endotracheal intubation. C. Is more important for paramedics than EMTs. D. Is difficult because their faces are much smaller. B. May avert the need for endotracheal intubation. D. Delivering each breath over 1 second until the chest rises visibly. C. Regurgitation and aspiration may occur, even with proper ventilation technique. 64. When preparing to intubate a small child, it is important to remember that the small child's epiglottis is very rigid. B. Prolonged attempts often cause tachycardia. C. You should hyperventilate before intubating. D. Small children have a relatively large occiput. D. Small children have a relatively large occiput. 65. The use of a straight blade during pediatric intubation. A is generally reserved for neonates only. B makes it easier to manipulate the epiglottis. C is associated with a higher risk of bradycardia. D facilitates laryngoscopy by lifting the vallecula. B makes it easier to manipulate the epiglottis. 66. The most appropriate ET tube for a 6-year-old child is A 4.0 mm, cuffed. B 4.5 mm, cuffed. C 5.0 mm, uncuffed. D 5.5 mm, uncuffed. D 5.5 mm, uncuffed. Closely monitor the child's cardiac rhythm. 68. A blank orogastric or nasogastric tube with the most appropriate size for a 4-year-old child. A 4FB6FC8F D10F. D10F. C. Prior to inserting an ING or OG tube in an unresponsive child without a gag reflex, you should intubate his or her trachea. B. Tachypneic and without retractions. 71. Signs of compensated shock in the infant or child include all of the following: EXCEPT, A. Abnormal mentation. B. Tachycardia and pallor. C. Prolonged capillary refill. D. Decreased peripheral perfusion. A. Abnormal mentation. C. Compensate more efficiently than adults by increasing heart rate and peripheral vascular resistance. 73. The approximate total blood volume of a 60-pound child is A. 2.2 liters, B. 2.9 liters, C. 3.4 liters, D. 3.8 liters. A. 2.2 liters. 74. When caring for an infant or child who is in compensated shock, you should A. Intubate at the earliest sign of altered mentation. B. Administer a 10 ml/kg normal saline fluid bolus. C. Assist ventilations to improve tissue oxygenation. D. Establish IV or IO access en route to the hospital. D. Establish IV or IO access en route to the hospital. 75. A child in decompensated shock with hypotension should A. Be intubated to protect his or her airway. B. Receive initial fluid resuscitation at the scene. C. Be given 25% dextrose to prevent hypoglycemia. D. Receive volume expansion with 5% dextrose in water. B. Receive initial fluid resuscitation at the scene. 76. Distributive shock in children is most often the result of A. Sepsis. B. Spinal injury. C. Heart failure. D. Anaphylaxis. A. Sepsis. 77. Early distributive shock in children is characterized by A. Warm, flushed skin. B. Weak peripheral pulses. C. Pallor and diaphoresis. D. Gross neurologic deficits. A. Warm, flushed skin. 78. A child in anaphylactic shock, A. should receive 0.1 mg per kilogram of epinephrine IM. B. is treated primarily with saline fluid boluses. C. may require a low-dose epinephrine infusion. D. should receive epinephrine 1000 via the IV route. C. may require a low-dose epinephrine infusion. 79. Unlike other types of shock, A child in cardiogenic shock would most likely present with an enlarged spleen. B. Unlabored tachypnea. C. Increased work of breathing. D. A primary cardiac dysrhythmia. C. Increased work of breathing. 80. Failure of a child's SpO2 to increase despite high flow oxygen is most indicative of a relative hypovolemia. B. Congenital heart disease. C. Right-sided heart failure. D. Decreased vascular tone. B. Congenital heart disease. 81. You should be most suspicious for cardiogenic shock in an infant or child if he or she appears listless or lethargic. B. His or her heart rate varies with activity. C. His or her heart rate is greater than 150 beats per minute. D. Perfusion decreases following a fluid bolus. D. Perfusion decreases following a fluid bolus. 82. Bradydysrhythmias in children most often occur secondary to a severe hypoxia. B. Drug ingestion. C. AV heart block. D. Cardiac irritability. A severe hypoxia. 83. The preferred initial pharmacologic agent for pediatric bradycardia is atropine. B. Epinephrine. C. Dobutamine. D. Amiodarone. B. Epinephrine. A is typically asymptomatic and does not require special treatment. 85. Which of the following is the first-line treatment for a hemodynamically unstable child with bradycardia? A. Epinephrine IV or IOB chest compression. C. Ventilatory support. D. Transcutaneous pacing. C. Ventilatory support. 'C' should be interpreted in the context of the pediatric assessment triangle and the primary assessment. 87. Which of the following components is not used to distinguish sinus tachycardia from reentry supraventricular tachycardia? A. Pulse rate. B. P wave presence. C. Systolic blood pressure. D. QRS complex width. D. QRS complex width. 88. Unlike sinus tachycardia, reentry supraventricular tachycardia in infants is characterized by a presence of P waves. B. An unvarying pulse rate. C. A history of fever or dehydration. D. A pulse rate greater than 180 beats per minute. B. An unvarying pulse rate. 89. The most appropriate vagal maneuver for an infant involves A. Blowing into an occluded straw. B. Holding ice packs firmly to the face. C. Firmly massaging the carotid artery. D. Applying a heat stimulus to the body. B. Holding ice packs firmly to the face. 90. If an initial cardioversion attempt is unsuccessful in a 33-pound child, you should repeat the procedure using blank joules at 10 bites 15 C30 D50. C30. 91. Hemodynamically stable children with a wide QRS complex tachycardia, A should receive amiodarone. B. Respond well to adenosine. C. Are likely experiencing supraventricular tachycardia. D. Will respond to vagal maneuvers. A should receive amiodarone. 92. Cardiopulmonary arrest in the pediatric patient A usually presents with pulseless electrical activity. B. Requires high epinephrine doses. C. Typically requires defibrillation. D. Is most often a secondary event. D is most often a secondary event. 93. Treatment for pediatric asystole includes A. Atropine, B. Epinephrine, C. Cardiac pacing, D. Hyperventilation. B. Epinephrine. B. Attempt to identify an underlying cause of the arrest. 95. Prior to administering pharmacologic therapy to an infant or child with pulseless ventricular tachycardia, the paramedic should perform A. Intubation, B. Cardioversion, C. Defibrillation, D. CPR for 5 minutes. C. Defibrillation. 96. Ductal-dependent congenital heart defects typically present with blank in the neonatal period. A. Hypertension, B. Low-grade fever, C. Hyperirritability, D. Respiratory distress. D. Respiratory distress. 97. Dilated cardiomyopathy is a condition in which the heart is A. Deprived of oxygen due to sudden coronary vasospasm, B. Unusually thick and must pump harder to eject blood, C. Temporarily impaired by an isolated bacterial infection, D. Weakened and enlarged, making it a less efficient pump. D. Weakened and enlarged, making it a less efficient pump. 98. Etomidate should be avoided as an induction agent in pediatric intubation in the presence of A. Hypovolemia, B. Tachycardia, C. Hypotension, D. Septic shock. D. Septic shock. 99. Common signs and symptoms of meningitis in young children include all of the following: except A. Poor feeding, B. Nuchal rigidity, C. Bulging fontanelle, D. Irritability and fever. B. Nuchal rigidity. 00. Meningococcal meningitis with sepsis is typically characterized by A. Purpuric rash, B. Insidious onset, C. Low-grade fever, D. Persistent cough. A purpuric rash. 101. Which of the following is the most easily correctable problem in a child with an altered mental status? A. Ingestion of aspirin 2 hours ago, B. High fever with a widespread rash, C. Blood glucose reading of 40 mg per deciliter, D. Dehydration associated with hypokalemia. C. Blood glucose reading of 40 mg per deciliter. D. Hypertension, tachycardia, diaphoresis, and mydriasis. 103. In children, complex partial seizures would most likely manifest with A. Focal motor jerking with loss of consciousness, B. Generalized tonic-clonic movement of all extremities, C. Focal motor jerking without loss of consciousness, D. A brief loss of attention without abnormal body movement. A. Focal motor jerking with loss of consciousness. A lasts less than 15 minutes, and occurs in children without underlying neurologic abnormalities. B. There is no relationship between simple febrile seizures and future developmental or learning disabilities. C. Nasal airway insertion and suctioning is needed. 107. Common medications used to treat pediatric seizures in the pre-hospital setting include all of the following: except A. Ativan, B. Dilantin, C. Diazepam, D. Midazolam. B. Dilantin. 108. The use of lorazepam for seizures in the pre-hospital setting is limited by its a short half-life, b. slow onset of action, c. long duration of action, d. refrigeration requirement. D. refrigeration requirement. 109. In contrast to toxic ingestions in toddlers, toxic ingestions in adolescents, A. are usually unintentional. B. typically involve multiple agents. C. are associated with lower mortality. D. involve small quantities of a single agent. B. typically involve multiple agents. 110. Beta blocker ingestion in small children would most likely cause acute hypoglycemia, B. agitation or irritability, C. marked hypertension, D. ventricular fibrillation. Acute hypoglycemia. 111. The management for any potentially toxic exposure in children begins by A. identifying the toxin, B. providing an antidote, C. ensuring a patent airway, D. assessing respiratory effort. C. ensuring a patent airway. 112. Which of the following is the most appropriate dose of activated charcoal for a 45-pound child? A. 5 grams, B. 10 grams, C. 15 grams, D. 20 grams. D. 20 grams. B. can cause severe diarrhea and life-threatening electrolyte abnormalities. 114. Any child with unexplained hypernia should be suspected of having blank toxicity. A. opiate, B. salicylate, C. beta blocker, D. organophosphate. B. salicylate. 115. The incidence of sudden infant death syndrome peaks between the ages of A. 2 and 4 months, B. 3 and 6 months, C. 4 and 8 months, D. 8 and 12 months. A. 2 and 4 months. 116. Identified risk factors associated with sudden infant death syndrome include all of the following: EXCEPT, a low birth weight, B. young maternal age, C. exposure to tobacco smoke, D. sleeping in a supine position, D. sleeping in a supine position. 117. Fever in infants younger than 2 months of age is defined as a body temperature that is blank degree Fahrenheit or greater. A 99.2 bites 100.4 C 101.2 D 102.0 B 100.4. 118. Which of the following is least characteristic of an apparent life-threatening event in an infant? A. pallor or cyanosis, B. a period of apnea, C. brief loss of a pulse, D. loss of muscle tone. C. brief loss of a pulse. 119. What forms of child maltreatment are often difficult to identify and may go unreported? A. sexual and emotional abuse, B. emotional abuse and neglect, C. neglect and physical abuse, D. physical and emotional abuse. B. emotional abuse and neglect. 120. You should be most suspicious for child abuse when caring for an injured 4-year-old child if there was an unusual delay in calling 9-1-1. B. the child presents with bruises to both shins. C. the caregiver demands that you treat the child. D. you can smell alcohol on the caregiver's breath. There was an unusual delay in calling 9-1-1. 121. Once you suspect that a child may have been abused, you should A. apprise the caregiver of your suspicions, B. Transport the child to the hospital at once. C. Question the child in front of the caregiver. D. Carefully document what you see and hear. D. Carefully document what you see and hear. 122. Bruises that occur blank are rarely incurred accidentally. A. In a toddler. B. To both shins. C. To the forehead. D. In a straight line. D. In a straight line. 123. An infant or small child who falls from a significant height would most likely experience a lumbar spine fractures, bilateral thoracic trauma, C. A traumatic brain injury, D. Bilateral femur fractures, C. A traumatic brain injury. 124. When assessing an otherwise healthy child who is injured, you notice that his general appearance is abnormal. This should make you most suspicious for a child abuse. B. A head injury. C. Hypoglycemia. D. Internal bleeding. B. A head injury. C. Children are more prone to intrathoracic trauma due to compression forces. 126. In contrast to adults, young children are more prone to liver and spleen injuries because the organs, A. extend well below the ribcage, B. are both highly vascular, C. are more mobile and less supported, D. are relatively smaller and less protected. A. extend well below the ribcage. Decompression injuries to the intra-abdominal organs. At the child's height and the height of the bumper upon impact. 129. In young children, airbags pose a particular threat for injuries to the A. thoracic organs, B. abdominal organs, C. head and neck, D. soft tissues of the face. C. head and neck. 130. When mechanically securing an injured child's head and neck to a backboard, you should A. place padding underneath the occiput, B. avoid placing a strap or tape over the chin, C. use towel rolls instead of a cervical collar, D. manually stabilize the child's torso first. B. avoid placing a strap or tape over the chin. 131. To ensure that an infant's head is in a neutral position during spinal immobilization, you should A. provide slight extension of his or her head, B. place padding under the infant's shoulders, C. place a towel roll behind the infant's neck, D. use towel rolls for lateral head stabilization, B. place padding under the infant's shoulders. 132. In contrast to the sample history of a child with an illness, the sample history of an injured child should include a specific inquiry regarding A. routine medication use, B. any known drug allergies, C. any prior hospitalizations, D. his or her last tetanus shot, D. his or her last tetanus shot. 133. Signs of pain in an infant with MOST likely include A. tachycardia and inconsolability, B. heart rate that is not variable, C. diaphoresis and dilated pupils, D. labor tachypnea and pallor. A. tachycardia and inconsolability. A child's larger skin surface to body mass ratio increases his or her susceptibility to heat and fluid loss. C. The purpose of the tube is to bypass a mechanical upper airway obstruction. B. Avoid using the central line if possible and attempt to establish peripheral IV access elsewhere. D. Have impaired circulation and absorption of cerebrospinal fluid, leading to increased size of the ventricles of the brain and increased intracranial pressure. B. Recognize that the caregiver is a key resource, and that his or her expertise should be utilized to assist in the care of the child. 139. Most injuries in pediatric patients, A. Can be totally eliminated with training. B. Involve trauma to the chest and spine. C. Are predictable and preventable events. D. Occur due to gross caregiver negligence. C. Are predictable and preventable events. B. Diplomatically ask the parents if their daughter can have some privacy. D. Visually assess the child from across the room for any signs of increased workup breathing. D. Manually maneuver her hand and reassess her breathing status. A. Administering high-flow oxygen as tolerated, auscultating his lung sounds, and being prepared to assist his ventilations. A. Fever and anxiety. C. Providing calm reassurance to both mother and child. B. Provide any immediately needed care, perform a rapid assessment, apply spinal precautions, and transport. D. Begin assisting her ventilations with a bag mask device, and assess her pulse rate. B. Avoid agitating the infant, offer supplemental oxygen, and transport. A. Assist his ventilations with a bag mask device. A. Perform laryngoscopy, and try to visualize the foreign body. C. Administering 0.25 mg of epinephrine IM. D. Allow the child to assume a position of comfort, avoid agitating him, and transport him to the hospital. B. Bacterial epiglottitis. B. Give 0.5 mg of nebulized ipratropium. A. Extubate immediately and ventilate with a bag mask device. C. Administering supplemental oxygen, keeping the child warm, assessing his blood glucose level, transporting, and establishing vascular access en route. C. Narrow QRS complex rhythm with absent P waves and a heart rate greater than 220 beats per minute. D. Initiate one rescuer CPR while your partner attempts to establish vascular access. B. Establish vascular access and administer a 20 ml/kg normal saline bolus. A. Perform immediate synchronized cardioversion and reassess. C. Starting an IV line and administering amiodarone followed by procainamide. B. Defibrillate with 40 joules and immediately resume CPR. A 81 mg of aspirin. D. Keep the child cool and transport him to the hospital for physician evaluation. B. Recognize that the infant has been deceased for an extended period of time. C. Open her airway with a jaw thrust maneuver, suction her mouth and nose, insert an oral airway, and assist her ventilations with a bag mask device. B. Administer high-flow oxygen, apply spinal precautions if indicated, provide warmth, begin transport, establish vascular access en route, and administer enough crystalloid solution to maintain adequate perfusion. D. Disconnect the child from the ventilator and begin bag mask ventilations. A blood pressure 140/92 mm Hg. Pulse 58 beats per minute. Respirations 8 breaths per minute. 170. A 6-year-old child has burns to his head, face, neck, and anterior chest. What percentage of his body surface area has been burned? A 21%, B 27%, C 30%, D 36%. At 21%.